Hello and welcome to our session today, talking about our collection of papers, which we'll be publishing over the course of the next week in the BMJ, which is very closely aligned to the theme of the conference. The focus of the papers is we've entitled it "The Road to Equity and Solidarity," and I think those two themes will emerge very strongly as our very excellent group of panelists present and talk to you today. So we're very delighted that you're able to join us. The themes we'll be covering in a little more detail today are very pertinent. We started work on this collection back in June of 2020. The papers have come together and are being published. 3 of them are published today. And it seems to me that all the themes and the issues discussed, the lessons that people are drawing upon, the ways forward that the authors are recommending are very, very pertinent and relevant to what's happening right here, right now with COVID globally, and also relate very closely to the findings of the independent panel earlier this week. So I think you'll find this conversation very important, very relevant. And I've certainly learned a lot by working with this wonderful author group and putting these papers together, and I hope you do so today. So today we'll talk more about the political economy of the response, the role of international institutions, how some health systems, many health systems have been overwhelmed by COVID, the role of social determinants, the value or the usefulness of the global indices of preparedness that we've used and what we might do in future, and importantly, the global megatrends that have driven this pandemic and how that relates to solidarity. So it's going to be a very interesting conversation. We want to have a lively discussion at the end. We're going to present for about half an hour and then to take your questions. So you will find at the bottom of your screen a Q&A box. Please leave your questions in the Q&A box, and I will select some questions then to put to the panel. If you want to talk and have a chat with people who are watching the webinar, then please do that via the chat facility. So have your side conversations with the chat facility, leave questions for me to select and choose from via the Q&A. Excellent. So now I'm going to turn over to our panel and ask them to very quickly introduce themselves and tell us what they will be talking about. So first of all, Jesse, hello.
Good morning, everyone. Good evening, time appropriate greetings. Thank you, Kamran. My name is Jesse Bump. I'm the Executive Director of the Talk to Me program and a lecturer on global health policy at the Harvard T.H. Chan School of Public Health in the United States. So welcome. I'm going to present a couple of papers today. I'll just quickly share my screen. I have been very pleased to lead these efforts with co-authors. They both relate to the political economy of COVID-19, and I'll explain what I mean there in a second. These are the 2 articles. One of my fellow panelists, Fran, here is a co-author on the first of those, Political Economy of COVID-19, Extractive, Regressive, Competitive. And the second paper is International Collaboration in COVID-19. What are we doing? Where are we going? With Peter Freiberg and David Harper. I'm going to present these 2 papers in sequence, but they have many intertwined themes, which is why I'm talking about them together. And if there's things that you'd like me to expand on or additional questions, please feel free to raise them in the chat or in the questions afterward. So thank you for joining me. And this is our...
Jesse, sorry, can I hold you there? I'd just like to introduce the rest of the panel, then we'll come back.
Sorry, sorry about that.
No, sorry, I should have made that clear. Yeah, Viraj, hello, introduce yourself, please.
Hello, my name is Viro Tang Tirnusathian from IHVP, which is a research arm of the MOH in Thailand. I'm going to present a paper, compare 3 health systems, China, Thailand, and New York states.
Thank you, Viraj. Fran, hello.
Oh, hi. Good morning, good afternoon, good evening, everybody. I'm co-chair of the People's Health Movement Steering Council, and I'm also a professor of public health at Flinders University. And I'll be talking about the work we've looked at on how well indexes predicted preparedness and how we think preparedness might be predicted better in the future.
Thanks, Fran. Lauren.
Good day, everyone. I'm Lauren from the University of Cape Town in South Africa, where I work in the Department of Political Studies and also a PHM member from South Africa.
Welcome. Lauren, tell us what you're going to be talking about, just very briefly.
So I'll be speaking about COVID-19 and the social determinants of health. And one of the co-authors is also Fran.
Fabulous. Thanks, Lauren. Joran, hello.
Hi, I'm Göran Thomson. I'm a counselor to the president at Karolinska Institutet on Human Agenda 2030. And I'm a senior advisor at SITE, Swedish Institute Global Health Transformation at the Royal Swedish Academy of Sciences. And if I may add, I'm an old friend of my colleagues.
Joran, what will you be talking about so people have a bit of a taster?
Okay, I thought I would make people even more curious, but I'll give it, I'll comply with the chair. I'm going to talk on solidarity and universal preparedness for health.
Thank you, Joran.
After COVID-19.
Thank you. Very good. Okay, we're going to go around all the panelists. We'll begin with Jessie. And I just want to say before we start, we're very grateful for the support of PMAC in helping us put this collection together. So thank you for that support. Jessie, take it away.
Oh, good. Sorry for my premature start earlier. I'm going to pick up right where I was. So these are the two articles I was mentioning. That first one with Fran Baum, with Milind Sorensen, Rob Yates, and Karen Hoffman, and then the second with Peter Freiberg and David Harper. And I'd like to thank our colleagues at PMAC for their support and our colleagues at BMJ for their assistance with these articles. So let me tell you a little bit about where we were coming from. We had, in both papers, we had one motivation. I'm sure you've seen maps like this one and similar ones from WHO and other places. But what struck us about this and what we wanted to investigate in the papers is that the distributions are really strange. You know, some countries have done really well, some countries have done extremely poorly. And then within countries, and that data on the right, those are from the United States, but they're found in many countries that marginalized people have been hit far harder than elites. We wanted to look at these distributions. They're unequal and they're unfair, and we wanted to know more about what causes them, what underlies them, and what we could do about it. So the first of these papers, The Political Economy of COVID-19, we chose to use a traditional meaning of political economy, which is about state performance. And typically that's measured in GDP per capita, in economic terms, but there's no reason that you couldn't do that in health too. Health is one of the most important areas of state performance. And in this case, when we looked at one country versus another, I think it's fairly obvious to most observers that some have performed really well and others have not done well at all. I'm sitting in one now that I think most people would agree is probably the world's worst performer. And we wanted to explain that. So we found, as we looked at it, we thought one way to characterize the political economy of COVID-19 is extractive, regressive, and competitive. The extractive and regressive part relates to how the burden of COVID-19 follows historic resource extraction. Internationally, that's from one country to another, and within countries, that's from some people to others. The competitive attitudes by some of these countries, that is making national purchases of scarce supplies, not joining or undermining the shared COVAX facility, making regional block purchases. So these things like national purchases, a great many countries have done that. The US has done that, the blocs, the EU has done that. Ordinary, respectable, often considered reasonable countries have done this. Norway has done it, Canada has done it. These are countries that have gone to drug producers and negotiated for themselves. And when they do that, they crowd out the supplies that could otherwise be redistributed on a basis other than price. So these are ways that countries have chosen to compete with each other rather than collaborate. The ethical imperatives and public health progress require governance reforms. This is where we ended up in that paper, because if there's only allocation by price, the allocation will be unfair. And if WHO doesn't have the power to compel countries to join the COVAX facility, and countries are unreasonable on their own, then we look to governance reform, which means at the multilaterals and between countries, as well as within countries, where you can make an argument based on the performance of COVID-19 about the effectiveness of universal coverage or other entitlement programs. So we felt that best overall in explaining the distribution of COVID-19 was this lens of extraction. And I'll be happy to say a little bit more about that, but I'll turn to our second paper, which is on international collaboration in COVID-19. What are we doing and where are we going? And this is a second take on the same kind of question. So we began from that same point of saying, well, countries have performed really differently. And then we observed that the very differences in performance suggest some limitations in learning from one other country. We noticed that there was no temporal pattern. So if you'll think back to, it seems like the time of dinosaurs, but a year ago, when we were thinking as a community that this new virus of unknown, unprecedented origin had appeared in Wuhan, China, what would it do? Where would it go? Initially, you might have suspected that the first country where the least was known and it appeared the fastest would be hit hardest, the second country, perhaps the second hardest, and then down the line so that the nth country might be pretty well prepared. And as we watched it spread around the world, I think we were disappointed if we had held that expectation. The countries that had their first case introduced or detected later largely did not perform better than countries that had had less warning. Then there was the competition between countries for personal protective equipment and later for drugs, as some were found efficacious, even sometimes for drugs that weren't efficacious, just based on speculation. The mutual suspicion between countries has also pervaded. So some countries have alleged that other countries are not making accurate reports of their data. Even within countries, some, like for example in Turkey, the medical association and the national government have been fighting over what the best reporting should be. In the US here, there's the same story with states, the federal government, and some individuals and universities disagreeing about what accurate data are. This kind of mutual suspicion, whether between countries or within countries, speaks to the lack of collaboration and the lack of solidarity for which WHO has advocated. So we wondered, how do we explain this in international collaboration? And this is the story we found. The beginning part is that shared objectives and shared advantages have drawn nations to collaborate on international health challenges. And they've done this formally since the Ottomans convened the first international effort, a sanitary court in the 1830s. Then there were the sanitary conferences that led to WHO. These began in 1851 in Paris. The League of Nations was in there. And then since 1948, we've had WHO. These are historic forces that draw nations together, even if they don't want to be, even if nations are competitors in most other ways, in political and military ways, they want to collaborate on health because the global connectedness of nations means that they have a very difficult time controlling disease as independent units. And they need to share information and knowledge, and setting rules and standards advances effectiveness and underpins trust. So there are all these efficiency gains. There are all these reasons, technical reasons, political reasons, why nations should collaborate. And their imperative to collaborate is shown in those institutions and that regular 200 years of meetings that countries have had. But underneath it, there's a tension because nations often don't want to collaborate. So what we see here against COVID-19 is the limits of that collaboration. We see poor performance as a globe. So some countries, yes, they've done well, other countries have done poorly. But I would say as a globe, we have performed poorly. In part, the evidence for that is the disparity between nations. the disparities within nations, and the lack of a temporal pattern. So we have seen, as COVID-19 has spread around the world, we have seen many ways in which the globe could prepare better, could perform better. And so what we have concluded is that when you look at WHO, you see the reasons nations should collaborate. And then you see the limitations of their unwillingness to do so completely. For example, they have limited WHO's mandate. This is a feature built in from the beginning, and it has been exemplified over the years with a series of moves, a couple of which I'm going to mention. But WHO does not have the authority to check national data. WHO does not have the authority to operate in areas where it is not invited to operate. WHO is required by its member states to accept whatever member states say. So in this pandemic, where it's clear that some countries are not doing well by their citizens, and where independent experts believe that some countries' national data isn't correct, WHO simply doesn't have the power to check on that. And that's a reflection of the absence of the authority from the member nations. So what we did in the paper was to look at the pattern in international institutions and to say that, well, at the Global Fund or at Gavi, those are areas where donors have agreed on a very narrow basis for specific missions. But the narrowness and limitations of those agreements are the reasons we've been unable to respond better to COVID-19 and will not respond well to any of the other global challenges that require our collaboration, such as climate change or any other emerging infectious disease. Thank you.
Really interesting. Just to say again, welcome to everybody who's joined us. Do leave your questions in the Q&A box, which is on the bottom menu, bottom bar of the screen. So look forward to seeing those questions from you. Over now to Viroj.
Thank you. Can I share the screen? Good morning and good afternoon, good evening. Thank you, Kamran, for this invitation. I'm going to present a paper co-authored by Mary Bassett. She was the health commissioner to New York State, and now she is with Harvard. Ching Yi Mung from PKU, Peking University, and Professor Anne Mill from London School of Hygiene and Tropical Medicine. It's on comparing three settings, China, Thailand, and New York State, whether COVID result in overwhelming health system or not. And our conclusion is yes, in particular, New York State and the US as a whole. So this is just published some minutes ago. It's a special collection by BMJ and support by PMAC. A bit of background. In January 2021, 1 year after the epidemic, China has 87,000 cases compared to 1.4 billion population and less than 5,000 deaths. Compared to US, they have 21.8 million cases and as of today almost reached 500,000 deaths. Thailand has a smaller population, 66, and we have less around, as of today, we have more than 10,000, in particular due to the second wave in December and January. And we compare the three settings. We cannot compare US as a whole because it is a state-federal relationship and there's a heterogeneous intervention across states. Therefore, having Mary as one of the co-authors and she knows quite well about New York State, then we pick up New York State as an epicenter of COVID in the US compared with China and Thailand. And the three authors from these three countries has involved closely with the COVID management, and Mill is the guarantor of the paper. What we compare is to compare with the WHO recommended action. These are the three groups of COVID response that recommended by the WHO. First, on preventing local transmission, in particular use of face masks, physical distancing in public spaces, test, and quarantine, and treatment of severe cases. Quite unfortunately, that the WHO has launched its guideline laid down in the road about May, that they launched a guideline on face mask coverage. And between January and April, country has diversity of implementation of face mask. Thailand thought that it does no harm. Then we implement almost universal face mask during the peak of epidemic, whereby there are disputes in Europe, in the US, whether face mask use is violating civil liberty or not. The second area is to mobilize a surge capacity of physical, human, and financial resources to perform public health function. And lastly, on governance arrangement, in particular, the whole of government orchestrated action to respond to pandemic. So we compare the three country implementation against the three actions recommended by the WHO. This is a little bit messy, but it covered three areas as discussed in the previous slides. Face mask is mandatory in public space in China. It's voluntary in Thailand, but both countries has high adherence, whereby in the US as a whole, there's a partial implementation with large variation across states. On availability of PPE, both China and Thailand has more or less self-sufficient on local production, whereby there's a critical shortage initially and reliance from other countries' supply in the US as a whole. On the treatment, we have both countries, China and Thailand, have USC, whereby Trump administration said the federal government pay doctor and hospital based on Medicare rate, but balance billing is not allowed. But there's a long queue because of huge surge capacity, surge number of COVID cases. Therefore, people, even they are covered by Medicare rate, they do not have adequate access and people die. As Jesse has said, particularly the Black and Hispanic community has the highest mortality. On the governance, there's inconsistency, insufficient and confused public message in the US as a whole, not only in New York State, whereby China and Thailand has a whole of government and a huge citizen adherent to control measures. China new hospital was built in 10 days, amazing. They mobilized 346 medical team, 42,000 medical staff, and 900 public health officers mobilized from outside Wuhan. This does not happen in the US, as far as Mary has confirmed. Thailand, China has adequate local production of PPE, not in the case of US. New York said there's a lack of federal government support, and they couldn't mobilize resources from outside state. And USC is the main driver for user access to treatment in China and Thailand, plus additional significant budget for test, trace, and quarantine. On governance, Thailand Public Communication Platform through the Center of COVID-19 Situation Administration, CCSA, they start operation since January until today, and will continue until tomorrow and forever until we can address COVID. The CCSA is a platform for a daily update of the situation and provide all the transparent epidemiological data. Also in China, both central and local government has collaborated closely. It is very unfortunate that Trump has politicized COVID-19 in the US, and there's a competing relationship between state authority and the city public health structure. And as I said, public communication is characterized by inconsistent, incongruent, and insufficient message. So this, the government, the poor governance in the US and in New York State has resulted in surge of cases and overwhelm of the health system. On the effect of COVID on health services, of course, both China and Thailand, we have a reduction of outpatient and admission during the epidemic phase. But in Thailand, we do not have interruption of life-saving services, for example, ART and dialysis. In New York State, COVID-19 death was 800 a day and around 23,000 confirmed cases before transmission began to decline. And more death among Black and Latino American, and substantial number of active cases overwhelm the healthcare delivery system. 4 key messages. Rapid increase in case seriously disrupt the health delivery system and create stress in health workforce. Even quite a number of health workforce die from COVID, and limited access to hospital service and increased mortality. 2, country evidence has shown that infection of COVID can be contained at a very early stage, hit hard and hit quickly through public health measures such as use of face masks and physical distancing. Quite a number of subsequent systematic review has shown that the effectiveness of face masks is very high in prevention of source and prevention of recipient from droplet infection. From the source prevention, it is because 90% or 80% of the cases are asymptomatic. And cross-sectoral coordinated action and effective test, trace, quarantine, treatment is so vital. And finally, all the intervention is governed by a country governance to ensure citizen adherence to public health measures and other social interventions. These are the key. So in conclusion, we find that in the US, in New York State, it's the real mess there, and hope Biden will really do something tomorrow. Thank you, Kamran.
I think we may have just lost Cameron for a second, but hopefully he'll be back with us in just a moment. So thank you, Dr. Viraj.
Should I go ahead, do you think?
Let's go ahead, Fran. I think we'll move across to you and then we can come back to Cameron afterwards. So please go ahead, Fran. Thank you.
Yeah, great.
Great. Thank you.
Great. I hope you can hear me okay. I'm talking about how we can explain COVID performance, which I think builds on Viraj's presentation. And you can see here that this represented a group of people who are sort of collaborating on looking at national COVID responses. And so we were quite a team. And I know that I think Eugenio, Camilla and Jenny are online with us today. So we really asked the question of what factors are important in predicting country responses. And what we found was that the Global Health Security Index, which is really the most prominent index hoping to predict responses to pandemics and epidemics, they did predict that the world was not very well prepared, but their predictions on country performance was much less accurate. In fact, as you can see from this, and there's deaths per million on the axis, and then the global health security scores along the bottom. And what you'll see is that the UK and the US were predicted to do very well, but of course they haven't, and the same with Belgium and other countries. So we then worked between us to work out, well, what factors accounted for the failure for the index to predict national performance. And I'm going to have to go through these very quickly because we've only got 5 minutes. But the first one was that geography, globalization and global governance were important. And perhaps there was more need to consider the mechanisms for international cooperation and international organizations such as the EU and the G20. We also found that there was a bias to high income countries. They needed probably a broader range of experts. It was quite US biased, and broader participation beyond biosecurity concerns to think about community participation and so on. There was also a failure to assess health system capacity. And I think that Viroj's, in his 3 examples, has shown that very well. And generally, we found that countries that were doing best were those with universal publicly funded health systems that were not financially distressed and had strong public health capacity. Political leadership clearly was a big issue, and political leadership that worked well was that had clear communication based on science and in which there was a high trust. And we also concluded that context was important because political, economic and social structures are dynamic. And this sort of index needs more of a system approach of what's happening. The 6th factor we came up with was that national wealth isn't a fantastic factor. In fact, the countries that generally have good health at low cost, such as Vietnam and Rwanda, did very well. And I guess we'd also add Thailand to that. There was also no examination of existing inequalities within the countries. And I think every speaker has said how important that is. And that the groups that were suffering the most health inequity before the pandemic were those that did so at the end during the pandemic. We also believe that social security provisions are really important to support people in unemployment. Something like sick leave is crucial so that people feel that they can stay home, they can follow the guidelines for not spreading the pandemic. We also found that the civil society capacity was not assessed, and yet social solidarity can offer protection and defend human rights. Example of that has been in Cape Town in South Africa, where there's been a strong civil society response that has filled the gaps from government. And finally, the gap between capacity and its application wasn't assessed. So for instance, the US had a really strong CDC, but it wasn't able to work effectively. So, and complex systems are really as strong as their weakest points. And that also links to the point about health inequities. So that was our 10 points. And we think that those 10 points can really give an indication of how you could better predict a pandemic. Okay, thanks very much.
Wonderful, Fran, and thank you. And I'll just step in while Cameron's just getting reconnected at the minute. But thank you for those important points. Just a reminder to everybody that we'll have plenty of time for discussion at the end to post your questions in the Q&A. And also these papers will be available, so you'll be able to go in and read more about what Fran's been talking about today. So let's carry on, and we'll come to Joran next, please. So Joran, over to you.
Thank you very much, Ashley. I'm very happy to be part of this for various reasons. One is the long-standing collaboration between Karolinska Institutet and leading colleagues in Thailand, truly reciprocal learning. The other, my other affiliation site, Biroj has been strong in his moral and intellectual support. This institute is only 4 years of age. I also feel very humble, because to talk on solidarity and universal preparedness for health after COVID-19 is not a small thing. And to try to describe it in 1900 words is even more difficult. Hence, I was very fortunate to work together with 6 leading colleagues representing 4 continents, low, middle, and high income countries. I would especially like to mention Sarah Chaucevic, without whom this would have been extremely difficult. I think she's listening into the webinar. Now, This pandemic was no black swan. Black swan being an unpredictable event with severe consequences. On the contrary, it was to be expected. Because megatrends such as demographic changes led us to encroach on habitats of species that are hosts to viruses with pandemic potential, and increase their opportunities to jump from one species to another species. Also in the era of hyper-globalization, the virus easily cross national borders. They don't need visa. Our 4 key messages are the following, and please read the paper. I don't have any slides. First, the COVID-19 pandemic has unveiled inequities and laid bare the growing crisis in global governance, as has been alluded to by previous speakers. 2, global demographic and environmental trends have long-lasting effects on global health and created the vulnerabilities exacerbated by COVID-19. 3, this interplay shows the need for solidarity within the global community to build resilient systems for the future. 4, a global multi-sectoral governance mechanism is needed to create the condition to support solidarity. And we suggest a universal preparedness for health concept, UPH. UPH goes beyond UHC, UHC being financial risk protection, access to quality service, medicines and vaccines. It does so by adding the time dimension. As being prepared is a global responsibility, a national responsibility, a local responsibility, and an individual responsibility to at least mitigate the next global emergency. Solidarity can be enacted through UPH access, geographical, generational, and socioeconomic. And the challenges are enormous, as we heard. UPH requires a multi, or if you prefer, transsectoral approach to mitigate the structural drivers of health and social inequities. Also tackling political determinants and power imbalances. Being prepared also means investing in people-centered health systems, as we heard. The interplay between megatrends and COVID-19 requires transsectoral and international collaborative response, briefly exemplified by 4 megatrends that you'll find in the paper. Demographic changes, rapid urbanization, as an example. Global environmental change, the environmental hazards, as mentioned. Power imbalances, we heard less of that. This enormous nationalism, protectionism, and complete lack of global leadership, and the technological innovation with the digital divide, such more difficulties in low resource settings without access to internet to have distance learning, and children not being able to be at school. So we must unite. We must unite around a global governance mechanism that tackle the determinants of health. In the paper, we called on the independent panel for pandemic preparedness and response to propose such a global governance mechanism. It was almost as this panel had read our paper, because in the recently, just a few days ago, released progress report, they express concern on the situation. They call on governments to step up. They regret the word, but high-income countries will have universal access to vaccines, whereas these will be difficult to access in low-income countries. They talk about the failures in preparedness. They also mention that the indirect effects of lockdowns, etc., will hit many low-income countries harder than the virus itself. and it will take lots and lots of energy and money to rectify this. They concluded the need for a fundamental shift so that pandemic preparedness is recognized as an obligatory investment, not a voluntary cost. Although this progress report unfortunately did not address what we asked them in the paper, namely a global governance mechanism, they are at least hinting at some barriers towards such a mechanism. And they talk, for example, about the geopolitical tensions, etc. Now, our paper also called on the ongoing Lancet Commission, COVID-19 Commission, to deal with governance mechanism. They briefly mentioned in the introductory page that they would look into good governance, but it was not part of their 4 priorities. Now, we conclude that a global collective action in support of universal preparedness for health is critical for a more resilient and just world. Thank you.
Excellent, thank you, Joran. I hope you can hear me. So I dropped off for a while, but I'm back. That's very interesting. Thanks, Joran. We've got some questions coming in, so we'll go to them very soon. But Lauren, I don't think we've had you yet. Over to you.
Thanks, Cameron. So I don't have slides. So I'll be speaking to something I've written that summarizes our argument. I'd like to start by acknowledging my co-authors, Salakshana Nandi from PHM India, Fran Baum from the Southgate Institute for Health Society and Equity at Flinders University, and also from PHM. Hani Serag was the 4th author, and he's from the University of Texas Medical Branch at Galveston. And then Deepika Joshi, also from PHM, assisted with some of the research for this article. So the article focused on COVID-19 and social determinants of health. And as Goran said, the impact of the pandemic is disturbing precisely because it was an entirely predictable crisis from an SDH perspective, a social determinants of health perspective. For example, the Alma-Ata Declaration convincingly argued that health for all could be achieved only through a new international economic order and people's participation in decisions affecting their community's health. These principles were affirmed in the report of the Commission on Social Determinants of Health and also the 2008 World Health Report. The Commission proposed, for example, tackling the inequitable distribution of power, money, and resources that drive systematic inequalities in health outcomes. And so, of course, what we're faced with today is the consequences of not taking action on those recommendations. So in different ways, these texts, which are widely accepted analyses of social determinants of health, have identified global solidarity, economic justice, and democratic decision-making as foundational to ensuring that everyone has a chance to achieve the highest attainable standard of health. So the one thing that was kind of foundational in the paper was to draw attention over and over again to the fact that positionality matters. And by that we mean that the effects of the structural inequalities we mentioned in the paper is mediated by intersecting social dimensions, including occupation, class position, ethnicity, race, migration status, and gender. And so what I'd like to do next is to draw attention to some of the long-standing structural drivers of health inequalities that we discuss in the article. So the first one is precarious and adverse working conditions, and these act as drivers of disease. So what we see with this pandemic is that people in precarious forms of work have limited access to sick leave, healthcare services. Often their low wages mean they can't afford sufficient and good quality food. They don't have access to water, sanitation, and housing. They may also be hesitant to quarantine because they can't afford to lose their income. And finally, they're probably unable to work from home. So what we see is that most workers in these jobs are from racial and ethnic minorities, working class backgrounds, or migrant communities. And of course, examples include meat workers, essential workers in logistics and shipping, retail and public transport workers. And we've seen the effects of the pandemic disproportionately impact workers in these sectors. The second structural driver that we look at is growing economic inequalities. So inequalities in wealth and income, and how these have undermined our capacity to respond to COVID-19. So globally, inequalities in decision-making power in the economic realm have decreased policy autonomy, particularly in the global south. And so here we could think of the pressure from the IMF on borrowers to implement austerity policies. We could also think in the global realm on the inequalities between dominant member states and less powerful member states in the global south when it comes to interpreting regimes like TRIPS, for example, and the use of the Doha flexibilities, or the Doha exceptions rather. Within states, we see inequalities in control over resources affect who gets access to care, and especially good quality care in a timely manner. At the national level, this is often a split between privileged care in the private sector and less readily available care in the public sector. So what we see, one, is that a key problem has been irrational use of resources in the private sector. So for example, in South Africa, over-testing in the private sector, which has meant limited access to diagnostics, human resources for testing, infrastructure, and so forth in the public sector. But I think also the paper shows that the pandemic has upended our assumptions about the quality of care in the private sector. And a good example of that is from Australia, where privatized care for the elderly has led to more people dying in private sector facilities than in public sector facilities. And then the final thing I think that we try and emphasize in the article is that resource inequalities and burdens of providing care, especially for the sick, is something that's profoundly gendered. So women have been affected more severely than men in terms of the labor time involved in providing care, social reproduction work, but they've also been severely affected by job losses. They've suffered disproportionate job losses because they work in sectors like the service sector, for example, that effectively has been gutted by the pandemic. Also something to note here is that most women are frontline health workers who are often the lowest down in the healthcare hierarchy, and so they're disproportionately exposed also to the risk of infection. And then at the same time, of course, you have news that the richest 5 billionaires enjoyed a 59% increase in their combined wealth during March and September through September 2020. So striking disparities and heavily gendered disparities. And then the third structural driver that we look at would be anti-democratic political processes and how these narrow the space to access healthcare, but also to hold political leaders in the private sector to account. So for example, control measures to contain the pandemic have negatively affected women and girls' access to reproductive healthcare and exposed them to sexual and domestic violence. Restrictive measures have been applied unevenly, so governments have used public health concerns to justify restrictive regulations vis-a-vis citizens, but fewer regulatory measures have been implemented in relation to private health care providers, manufacturers, to facilitate access to things like COVID-19 treatments, medical technologies, and healthcare facilities. And then at the global level, there's been a kind of restriction of democratic space in the sense that pharma and philanthropic foundations often make key decisions or have more power than some states, for example, states in the global south, in designing mechanisms designed to distribute, or ostensibly designed to distribute vaccines, for example, more fairly. So I won't speak to the recommendations in the article. I think, people will read that once they go to the journal. But in closing, I'd like to say that the notion of crisis isn't simply a metaphor or an abstraction, because every day COVID-19 patients, their families, friends, co-workers are confronted by loved ones facing a turning point in their disease. And as we know, one of the senses in which crisis has been used historically is exactly a turning point in a disease that can change whether one lives or dies. And in the case of COVID-19, this crisis state often lasts for days or even weeks, and they're often filled with despair. And I think when people are confronted with that on an individual level, they often think about the fact that this need not have been the outcome if their general state of well-being was better prior to infection, if their daily living and working conditions could have ensured that they lived a healthy life, if health systems were accessible, and if their governments didn't have to beg for access to know how to make vaccines, or that they didn't have to fight to be able to pay often inflated prices for diagnostics, PPE, or vaccines. And so I think that is one of the really disturbing aspects of this pandemic. And so to call COVID-19 the crisis is really a misnomer. And the point of the article was to describe the many ways in which COVID is a symptom, a new and deadly one, of an ongoing crisis driven by ever diminishing circles of inclusion, and then also a tendency to privilege profit over solidarity and health for all. And unless we tackle those structural dynamics, the unnecessary misery they create in the conditions in which people are born, live, grow, work, and age, those conditions will continue to cost lives and also poor health in those that survive this pandemic. Thanks.
Thank you, Lauren, and a very powerful set of presentations there. Thank you all very much. I'm going to go straight to the questions, but the two themes, equity and solidarity, very much came out strongly there. We've got a very good number of questions. I'm going to try and get through as many as I can. The first one is for you, Joran. From Livio Vadrasco, how does the UPH relate or not to the newly proposed Universal Health and Preparedness Review process? And also, there are other pandemic treaties being proposed, maybe changes to IHR. How can we best orchestrate these multiple initiatives?
Thank you.
A short answer, please.
I'm honored with the question, and I have to make you disappointed. I'm not. If I would be if I would be the boss of the world, then I would facilitate coordination. But I simply cannot, in an evidence-based way, tell you how universal preparedness for health relates to some other initiatives. What is obvious is that there is a need for a universal preparedness for health concept, and that there is a need for relating this to buzzwords and global policies. One of the three pillars of WHO, which is universal health coverage, but that one is lacking the time perspective. And this all needs a new governance mechanism. Maybe there is time for a Bretton Woods conference, like the one after the Second World War. I think that Kamran is looking at me and tells me, stop, Göran. And I will do that, but I'm very happy just for those that, the person that mentioned this, just interact with me, and I'll try to, we can have a communication around it. We have to assist each other here. It's a new global world order.
Thank you, Joran. You've just shown me you'd be perfect to be boss of the world. You've got my vote. Okay, so next question. I'm going to go, Jesse, straight to you. If we're saying the multilateral system and it hasn't worked, it's failed, and this is from Vikash Keshri, and I'm paraphrasing. Is it because some of the the more prominent nations have been so wound up dealing with their own pandemic response that they haven't been able to think about the multilateral side of things? Or is that not acceptable as an excuse?
Yeah, I appreciate that question, and there's a couple others that are similar. I'll try to answer a little bit of them all at once, and if people want to contact me, please feel free to do. I'm easy to find on the internet. But look, the fact that the rich countries have to do so much in the world that they created is one of the big problems. You know, it shouldn't matter if one country is not doing very well, like, you know, distracted by domestic politics or happens to be led by a sociopath. This is humanity we're talking about. The systems need to be more resilient to that. And many of the questions there in the sidebar are getting at this issue of what do we do about it? And I would point not to the multilateral system per se. You got to look at the member states. The member states have created part of WHO as a complaint box, and they point to it as if it is responsible for things that they themselves are actually responsible for. So if you want to know why do they have unequal governance structures, it's because the rich countries set it up that way. And the revisit Bretton Woods idea that Joran was just talking about is, look, it's a perfect time to do that. Bretton Woods was a good step toward global governance, and it's at its limits. You know, it's designed to contain conflict, not solve it. Look at Syria, one of the world's greatest disasters in all of human history. And all the rich countries will do is stand around and say, not me. We need to do better. We need to do better on that. We need to do better on climate change and on COVID. So I fully support this idea that we would revisit the ways that we govern ourselves.
Thanks, Jesse. I'm going to come back to all of you with a final question, but before that, a question for Viroj, Fran and Lauren, which is around, we've talked about the multilateral system, we've talked about member states. What about citizens? I mean, I think there's a question there about the role of citizens and their responsibility. How do we factor that in? Fran, I'm going to start with you, then go to Viroj and Lauren.
Yeah, well, I think it's really, really important. And I think I saw Jenny Poppe's question about how can we get better at measuring the capacity of communities and citizens and using lay knowledge. And I think we have to do that. One of the challenges is that it's, you know, it's one of those things that is hard to measure. It's not so easy to measure. And often we just go for things that are easy to measure rather than the things that are important to measure. But I certainly think measuring the strength of civil society, the sort of levels of solidarity in a country are really vital if we're looking at how well a country's prepared for a pandemic, a future pandemic.
Thanks, Fran. Viroj, quick thought from you on this.
Yes, I think there are interaction between citizen and their government. It's called institutional trust. Systematic review has shown that higher trust has better control. Therefore, the trust that government institution, the police, the armed force, the health sector is so critical to ensure that the country is better perform or not. There's smaller and quite big gap of trust in the US and decaying, according to the US survey, compared to many countries in Asia, in the Oriental part. There are much higher trust and much higher adherence to social measures. Over to you, Kamran.
Thanks, Viroj. Thank you for that. Yeah, trust is very important, as is measurement. Lauren, a final thought on this point from you.
So, I mean, it's interesting that you use the word citizens, because I think one of the tells in looking at the impact of the pandemic is that maybe citizens don't exist anymore, in the sense that citizens historically have been people that are entitled to certain social benefits, and that there should be a collective response to promoting their well-being. And so one question is, what should citizens do? Well, it could be to reclaim citizenship and to insist on a stake in decision-making processes, including processes about how money is spent in the healthcare sector, you know, to demand that social welfare benefits be restored. I think one of the reasons why the effect of the pandemic has been felt so severely is because both in the global north and the global south, the adverse effects of not only the pandemic, but decades of privatization of social welfare services have meant that people have to respond to this in a kind of individualized way. And so I think building back a collective response is key. Becoming citizens again is key.
Thank you. Thank you. So I think very good points: measurement, trust, and a collective response. There are several questions, which I'm sorry, we're not going to have time to get through all of them. I've got one more question in the interest of time, which I'm going to put to all of the panel. And there are related questions around to this one, but I'm going to ask the one from David Harper, who I want to thank because David played a big role in conceiving this whole collection of pieces. But now he's asking, now that we put the collection together, whether solidarity is in fact a pipe dream, because every country has its own interests, as David puts it. So, I mean, are we really chasing something that's unrealistic in terms of solidarity? Jesse?
Yeah, I mean, I think it's a great question, but the dream of equality, of fairness, of participation, of proper governance, look, that's as old as humanity. I don't think it's time to give up. In these dark times, it's time for people who care about it to band together and demand change. I think, you know, what Viroj and his colleagues have done in Thailand should be an inspiration to all of us. And what people have done historically to move from regimes characterized by overt legal slavery to independence. We're still in extractive stages, but look, I think as MLK said, the arc of the universe bends toward progress, and it will only do that if we demand it. I think it's time to be much more activist and much more forthright about this, because the forces that oppose us are not subtle. They are dominant, and they are relentless. It's time to organize and demand better.
Jesse, thank you. Viraj?
Thinking of global solidarity is too far away. It's in utopia situation. The most realistic is to hold government accountable that they have to build up national solidarity. And if countries have that solidarity across multi-sectoral actions, that country should be in good shape. I don't think we can pursue global solidarity in a quick way. And I challenge Joran, your universal preparedness for health is a challenging task.
Absolutely.
But we have to
very
deal
true.
with it.
Very true. Thank you. Fran?
Yeah, well, I think if we want a world where solidarity is much more widespread, then we've got to have a much more equal world. And in the last 2-3 decades, the sort of Gini coefficient of the world has got worse and worse. We've become much less equal. And we know that societies that are equal have higher levels of trust and the sort of things that can measure solidarity. So I think unless we can reverse what are becoming obscene levels of inequity, then we can't expect to have solidarity. I think they go together very, very much.
Thank you, Fran. Lauren?
So, I mean, I think solidarity is a life and death issue. And I say that in the context of the HIV/AIDS crisis in South Africa. You know, right now, South Africa presides over the largest ARV treatment program in the world. And partly that's only possible due to global solidarity in driving down prices for ARVs. So I think it's possible. I think one of the concrete ways in which solidarity could be expressed in this moment is to support the TRIPS waiver request tabled by South Africa and India and co-sponsored by many other countries, which is up for discussion again in February this year. And that's a concrete way in which we can make sure that people have access to life-saving medications, but also that decisions about health can actually be made by states rather than private for-profit corporations.
Very good, thank you. Joran, final word on this from you.
I'm going to take some more than a couple of final words.
Okay, all right.
Without visions, no future. Huh? Number one. Crisis always lends themselves also for opportunities. As Jesse said, you know, we don't have a choice. We have to act. And I think of Professor Pravesh Vase's triangle that moves the mountain. This is truly a mountain, a major, major problem. So then knowledge, generators needs to work with civil society and policymakers, and we shouldn't give up. And as my friend Biroy said, this cannot be solved on a global level only, but it has to include also a multilateral investment and mechanism. But it needs to be dealt with at the national level and at local level. One of my favorite expressions is glocal. You need to act, think and act both globally and locally, and it's very applicable here. I very much like to be challenged, and it's a very good question. Issue of solidarity. We wrestled with it in our paper, whether we should keep it or not. And we decided to keep it because Kamran, you requested us to do it. You may have forgotten. Then you criticized us for doing it, and rightly so. And I believe that solidarity in itself will not function. That's human nature. It has to go with, and I will finish with this, it has to go with what colleagues in this excellent panel mentioned, namely accountability and justice. And that's a mountain, a triangle that we need to work with. And I hope that you at BMJ will take on the baton, summarize the challenge, because I haven't read all the papers, but it would be interesting with a synthesis, listing, you know, a couple of the things that needs to be done in the world. And this should be published ASAP, as we now have a new leadership. But it should also include reactions from people that have not been involved in this exercise, that should be given a chance to react, comment, challenge. So yeah, that's one way of dealing with this. Thank you, and over.
Göran, thank you. That was very well put. I want to thank all of the panelists. I think it's been a really wonderful session, really informative. It's convinced me even more that we need equity and solidarity, if I can say that, as we move forward. And I think you've all picked up on themes. You know, Jesse, you talked about equity, but you also talked about activism. I think that's important. Viroj, you spoke about accountability. Fran, you focused on the equality part. For Lauren, you said it's a life or death matter in some parts of the world, and absolutely it is. And Göran, you finished off by, you know, with various challenges. It's local. We need justice, but also we need to act. We need to climb that mountain, and we need to do that together. And I hope you will enjoy this series of articles, which begin publishing today. Will be published all by next week on the BMJ's website. And yes, we will look at ways to follow up and see how we can act on the basis of these. So thank you to all our contributors today, to all the authors who have contributed but haven't been able to join us today because of limited time, the reviewers who helped us, to my colleagues at the BMJ, Rachel Hinton, Jacqueline Annis, James Ross and Ashley McKim, and most of all, we appreciate the time and the space and the support given to us by PMAC. So thank you all so much. Thank you all for the participants who've given us such wonderful questions and input during the course of the session. I hope you enjoyed it, and we'll speak to you again. Thank you all very much. Goodbye.
Bye-bye.
Bye-bye.
Thank you. Goodbye.